Good afternoon, everyone. Thanks for rejoining. We have for this afternoon session 2 panel discussions, one around youth type 2 diabetes and the other around diabetes in pregnancy. These are largely clinically focused, and we've got some really incredible panelists who are joining us here in Darwin. So I'm going to pass over now to Michelle Scerri, who you met earlier before lunch in the previous session, who will chair this next session. Thanks, Michelle.
Okay, thank you. We're going to kick off the panel on youth type 2 diabetes with a really lovely video from one of our peer facilitators, Edwina Murphy, who's going to join us also on the panel. We can try that. Let's choose it. We could just go straight to the. Yeah, we'll go straight to the video. Yeah. Thank you.
I'm Edwina. I'm one of the peer facilitator for Menzies, based in Catherine. I work with Menzies. I teach about what is diabetes. Found out that I had diabetes when I was, I think, 12 years old, and at that stage, I didn't know what it was. So growing up with diabetes, I've been all over the place, like eating sugary stuff. Got into hospital, I think, 4 or 5 times. I didn't have support. It's just mum being there with me. At that stage, she didn't have any complication with her diabetes, but she was just telling me about what are the medicines for. But I wasn't interested in it. So at the age of 18, I started having more complication for my diabetes. Had more tablets for my kidney. Then mum had complication with her eyes. She lost one of her eyes, and then I left school around year 12, moved back to my dad's country, and then in 2020, I think 2020 or 21, mum lost her kidney around 2018, 19. Took her 3-4 years on dialysis, and then after living in my dad's country, I moved back in 2021, I think, 21 or 22. Mum finally got a new transplant. I moved back, and from then on, I still was around in town. At that stage, I wasn't really interested in my diabetes. I was just taking the medications, listening to doctors what they keep asking me, do you know what diabetes? I just sit there telling, like, with the confusion face expression. Sorry. But when mum got her transplant, I finally understood what she'd been through, losing both of her eyes. I think her left foot got cut off and her toes, sorry. And when mum had all those complications, I finally made a decision to myself, like, I think it's more important to pay attention to what I eat or drink, especially taking medications. It is important. And after mum being away for 2 years in Adelaide, stayed in Darwin for, I think, another 2 years, I finally understand that after I joined Menzies, with Whirly, and then Whirly Mob told Menzies that they want to join us and then teach young kids about diabetes. That's when I find this job was very interesting and kind of helped me manage my diabetes until today. I think it helped me be confident, like, around people, like, especially with diabetes or some of them with no diabetes. It brings me out of the darkness, like I'm free, like I'm finally happy for myself.
Can you hear me okay? Yeah, great. Well, good afternoon, everyone, and welcome back. So we have here something that exists nowhere else in the whole northern part of Australia. We have a full and completely competent youth diabetes care team. So we're going to go through a case presentation, and what I'm really hoping is that we can discuss the clinical elements of the case presentation and what the model of care might look like and some of those things. But I think what I'm hoping is that we can really try to understand what a multidisciplinary team looks like in the context of looking after a young person with diabetes. In the spirit of, in our youth group, we've been talking a lot lately about social and emotional wellbeing and identifying feelings. So I'm going to ask our panelists, who I'll introduce in a moment, to talk a little bit about the work they do, but also when we present the case, just to talk about any emotions that it might evoke for them when we're dealing with young people with diabetes and it's complicated, and how they might manage some of those emotions in their day-to-day work. So I'll start from this end. So we've got Edwina Murphy, who you've just been introduced to. She's one of our peer facilitators working on the Menzies project. We have Fiona Sellars, who is a nurse practitioner and credentialed diabetes educator from Weipa in Far North Queensland. She'll tell you a bit more about her work. We have Dani Stanley, who's an Aboriginal health practitioner who currently works with NT Government at Katherine Hospital and previously done lots of work at Worley, hence she's inherited one of these beautiful shirts. We have Zoe Fitzpatrick, who's a child health nurse and is working in Congress in Alice Springs. Dr. David Simon, who's currently working as a GP in some of the remote Northern Territory government clinics across the Big Rivers region, particularly in the east, and has previously worked as an obstetrician and been really around the territory for a long time, currently based in Katherine as well. And we've already met this morning Professor Brandy, who gave an amazing talk. So we have a paediatric endocrinologist, we have a GP, a child health nurse, an Aboriginal health practitioner, a diabetes educator, and a peer facilitator. How can we go wrong? Okay, do you mind? Are you okay to flick? Thank you. And they can't see the slides, so that might prove a little bit of a problem. We might have to do some refreshing as we go. So just to note that these are fictional cases, although some of it will feel familiar because the themes are common. So case one, and I'm going to call this case Junior because we need a name. A 7-year-old boy who's been diagnosed with type 2 diabetes after he was screened with a HbA1c due to his obesity. He's got a body mass index Z score of 3.2, elevated waist to height ratio of 0.65. He's got acanthosis on presentation, and his initial HbA1c is 8.9 or 74 millimoles per mole. Thanks, Anthony. There's a really strong history in Junior's family. His mother had type 2 diabetes during her pregnancy with him, and his father also had type 2 diabetes. He has multiple aunts and uncles who are affected, as well as older siblings who developed their type 2 diabetes in adolescence. And his mother's just about to start dialysis. The social context is complex. The family are really concerned about his diagnosis. They're currently living in a remote community. He irregularly attends school. The family's quite mobile, so they move around from one community to another. And there's a story of food insecurity, and there's a background of some trauma history. He also has a diagnosis of rheumatic heart disease, and the family support him with his monthly LABs, and I think he's got really quite good adherence to that. So first presentation for us, meeting him, he's got, as we said, an elevated BMI and an elevated waist to height ratio. He's got evidence of acanthosis, which you can see in these pictures. He's got a borderline high blood pressure for his age, large tonsils, and otherwise not dysmorphic. For all the clinicians, he's got some pathology results which show his lipid profile with an elevated LDL of 4.4 and a low HDL. He's got some mildly elevated transaminases on his liver function test, and his urinary ACR is elevated at 15. So I hope you've remembered all that. What I'd quite like to do is actually start with Edwina. I mean, I guess if we think about, we've probably come to you guys down the track a little bit, because if we think in the real world context, it might be that a young person has contact with the most local people first. So Edwina, I was just going to ask you, when you hear that story, does any of it sound familiar to you, or what do you think about? And if you had a chance to talk to this young guy, what do you think you'd talk to him about? What would you talk to him about if you were seeing him, say you came along to the group or something? Is there anything you'd start by talking to him about?
I would talk to him about, like, as a start off, I would like get to know him first, and then once he's comfortable, then I can talk about the medication I take, and so he can understand that so he can understand that the medication that I take, that is clearly like, yeah, I would talk to him about the medications, and
It's great, thank you. So you get to know him, and then you might talk to him about your experience of the medications. That's great. It's a really good start. The next person that Junior meets on his journey is walking into the clinic and meeting an Aboriginal health practitioner, and that's Dani. So Dani already knows that this young fella has diabetes, and she can see that he's a bit overwhelmed. And what would your approach be like, and what do you think the priority is to try and work on in the beginning?
Probably just to get to know them and hear ask them if they know what's happening, or try and see how they see the situation or what they're going through. Probably get to know their family or whoever comes in with them. Try and make sure they see the same people every time they come in, like get familiar with them, get them used to us when we're in the clinic. Catch up with Edwina. We'll go and meet them whenever we can. I'm not sure, yeah.
Yeah, that's great. That's great. I did forget to ask you, how does it make you feel? Are there any particular feelings when you hear a story like this?
Yeah, or you hear very similar, being a part of many, the same. Yeah.
Okay. And working alongside the Aboriginal health practitioner is our child health nurse, Zoe. Zoe, what do you think on your first time you've met with Junior, or the first time you've met him after his diagnosis? What are you sort of thinking about in terms of his priorities of care, or how are you going to start to work with him?
Yep. So where I work at Congress, I team lead a chronic disease program for kids from 0 to 15. And I say we've got about 50 clients on our list because we're a small team, but a third of them would have diabetes or be insulin resistant. So this, unfortunately, we've got a few kids with pretty much exactly the social background, the medical background, down to the results. So the way we work is we'll get a referral first, usually from the hospital or from other clinicians at Congress, sometimes schools as well. And with I'd look through the referral, make sure they're eligible, because we're really trying to crack down that it is for chronic disease kids. We do get some referrals that are maybe bordering, or it's about non-attendance to appointments or something. So I'll go through the referral, and then once I find that they're eligible, we'll make a decision as a team on our program to get the family in, and we'll make that first initial meeting about getting to know the family and the patient. So I've only been the team leader in this program for the last 6-7 months, but before that, child health nursing at Congress for the last couple of years, and then just on the floor as a regular nurse for the last 4.5 years. So before I started at CHOP, there wasn't really a system like that. We would get them in as clinicians. You're opportunistic. You finally get to see this kid you've been looking for a long time, so you'll try and just do everything all at once. So that was the approach initially, but then I found that I didn't like that we were overwhelming these families as they come in, trying to do a full health check, trying to get their heart needles in, whatever they need. So we've taken that step back and said, even though we know this kid needs a lot done, we're just going to get to know the family first. So we get them in, we'll ask about how many siblings they have. Obviously the carers, whoever they are with them. If they're going to school, what community they're from, what do they do in their downtime, what do they understand about their condition, if they're on any medication, if there's any other services involved. We'll try and get as much information as possible, and just talk to them about what we do as well. And then we'll have a follow-up appointment on to address those medical needs. So yeah, in this situation, we would do that. And since we started doing that, instead of just going straight to a health check, we've had much better rapport and engagement with the families.
Yeah.
Because once you come onto our program, you can be short-term. Like we might get a kid with few, like a heart defect or something that just needs some specialist review for a few months, intensive medical treatment. And then they'll go off the program once something resolved, or the family's able to manage it themselves. So we can have short-term ones, or we can have long-term. We've got kids on the program for years and years. So we really want that first impression to be really good and welcoming, and they feel safe, because obviously there's a lot of programs around there, but ours is, we get involved very much into their lives. So
that's
yeah.
brilliant. So you're really setting the scene for a long-term relationship
Yeah.
that's going to work. That's brilliant. Thank you. Fiona is the diabetes educator who comes to visit the remote community where Junior's being seen. And what would your approach be? And feel free to say how you feel about this too, but what would your approach be in these early stages?
Well, I guess initially about how I feel about this is just in the background, having the understanding of what this long-term trajectory is for this person, and trying to sort of manage how I present that to the family as well. Because it's quite, upsetting, obviously, when he's already showing signs of developing complications. So if we put it in a remote context, looking at this family, so he's already having issues attending school, and we know that he's changing communities. So initially, obviously, getting to understand the family as well, about what that looks like, who's in the room, ensuring the right people are in the room as well that are there to support them. So if it's mum, recognising that she's going to be having dialysis, or is it going to be some of his siblings that are going to be supporting him? Where is dad in the picture? Where are the extended family? Sorry, closer. Yep. And then making sure that they're in the room as well, and working out what the priorities are for the family as well. So what are the existing barriers that we can attempt to address? So getting the health worker, health practitioner in the room, getting the peer support people in the room, trying to work out, are there financial barriers that are stopping them from attending school? Living remote, is there travel issues that are impacting getting to school, getting to clinic, trying to address any of the barriers initially? And then from a diabetes education perspective, like really getting them to sit down, as has been presented earlier today, around the Feltman, so understanding that condition. But if we can talk to them about the albuminuria as well, so talking about what that looks like for their kidneys and explaining about how a kidney is the filter and the reason that there's albumin in the urine is because there's high glucose levels, but there's also high blood pressure, and we're seeing that high blood pressure reflected with this test result, and then also linking that into the cholesterol. And so talking about how the LDL is elevated and linking that then into the liver, like the liver function test, and talking about that. And so obviously I get up pictures of what a healthy liver looks like and what a healthy kidney looks like, and talk about what they can do as a family now to prevent that progression or to delay that progression. And so really providing that education to link all of the abnormal results through. So then you're saying, okay, so now we can bring your blood pressure down by healthy eating. And so if we eat more vegetables and ensuring that a third of our plate is vegetables, then this is going to help your blood pressure. If we swap out the soft drink for non-sugary drink, preferably water, this is going to help your kidneys and your blood pressure. So linking it all through, like, with health education.
That's brilliant. And I think I'm just taking into account what Zoe said about, that we can overload families pretty easily with all the things we want to do in the early stages. Do you have a way you sort of prioritize or have a, like a timeline that you want to try and get all that information?
Ask them if they've got questions. So I'll just start. What do you know about diabetes? Asking for what their burning questions are. Is there anything that's worrying them? Yes, mum, had dialysis. Okay, the way we can prevent dialysis is this.
Great. So you're tailoring it for each individual family. Yep. Fantastic. Dr. David flies in for his weekly visit, and Junior's come to the consult room for some management suggestions. So we're really thinking about his initial management. At this stage, he hasn't really started on anything. What would you like to do? How do you feel, and what would you like to do?
So I'm feeling sad and I'm feeling powerless, but whatever I'm feeling, I'm thinking it's way worse for this family. I'd be trying to make some connection with the family. In my experience, perhaps because I find it, it's quite hard. If I start asking questions to a 7-year-old, I won't get any answers. So I'll probably be talking to mum or dad, and then maybe engaging with what he might enjoy. Does he follow AFL? And he might be wearing a Hawthorn jumper, and I'll say you should barrack for Collingwood. Or I don't know that I'd be. Oh, yeah, well, that's right, actually. But I'm not sure that I'm doing anything in the first conversation other than trying to make a connection with the family. And as a GP, I'm not going to be primarily managing his diabetes. So my responsibilities will be a referral. It'll be, thinking about who else might be useful. So is it possible to get you guys involved from Catherine? We don't have a diabetes educator in the region. So is there, other than at Worley, and they don't come to the government clinics. So I'm thinking, how can I advocate again for that? So that's, and I'd be trying to say what my role is, and I'm coming out here regularly. And so if there's any questions, that would be my approach. I don't think I'm going to be doing much on the first visit other than trying to gather resources and make a connection, really.
That's brilliant. So you're feeling quite lonely in that consult room, and you're wondering what your supports are. And I'm just really interested to hear again from Zoe, because you gave us lots of background. So your team spent lots of time getting to know this kid. How do you then facilitate contact with a primary healthcare team, like a GP or whoever's looking after them? Do you help with that, with what David's been talking about trying to build that rapport? And
yes and no. So we've got our own GP. Right now she's 0.2 with us. So we go to 2 afternoons a week. So we use that time, we'll purposely line up that time to tell her about new referrals, and we'd go through them together. things like that. So I guess essentially all things CHOP, which is the program related, come through me, and then I'll filter it to the GP. And then we come up with what the plan is together, and then also liaising with peds, who we are on the phone with 24/7 as well. So, but prior to me being in this role as a child health nurse, I'd work in a clinic, I'd have GPs, I'd have diabetes educators, I'd have things, other, people around me to go to for the best support. But in my role currently, yeah, we do have access to a GP. So it's really handy.
Right. It sounds very supportive. Yeah, it's really good. And then even though we're remote and there's no pediatric endocrinologist in the Northern Territory, luckily we've had somebody flying from Canada, which is timely. And so so we quickly pull in Junior and his family to come and meet with you, Brandy, to talk about his care. And you might talk a little bit about initial management, but please feel free to go on to what you might think of down the track too. And I am interested to hear how you feel too in these sorts of situations, even though you've got lots of experience.
Yeah, it doesn't get easier. That's certainly true. You've already seen me cry today, so we won't do that again. No, it's very touching, and a lot of these families, like I said, I know them. Like I know grandma, and then I know mom, and now I know the children that they bring in, and so I have some historical knowledge of a lot of these families as well. I go to communities, so I go. I take 8 trips a year to the northern communities to see the kids. But more importantly, I'm a resource for the people who work in communities. So usually what happens is I get a call from the nurse in the nursing station, then we discuss the case management of shared care, and then I talk to the GP, and because those kids trust those people. They don't know me, but most of them know somebody in community already, and so that's a much kinder way, I think, of introducing new people to their care team, is to have us all on board and having the same messaging. And so I do a lot of that, a lot of telehealth, a lot of video conferencing to save families travel as well, in terms of just the way we provide care. But when I see families, I mean, this is pretty common, and the biggest issues really are, what's the belief about diabetes and medication. So if mom's on dialysis, I have a lot of families who say, well, mom was fine on tablets, and then we put mom on insulin, and then she went directly on dialysis, and so don't put my child on insulin, it means dialysis, right? The understanding of the medications and the implication that as you get worse, we intensify medication that are then directly related to outcomes, is something that we have a lot of frank discussions about in terms of our team. The great thing about this kid, if I can say that, is that someone screened them. So I don't see kids with A1Cs of 8.9. This gives us all kinds of opportunity, right? Because if this kid came with an A1C of 10%, they need insulin. There's not really a question about that in terms of metabolic control. But with an 8.9, right? If you go by guidelines, it's over 8.5, you're supposed to give insulin, but most of these conversations happen in partnership with families. What could this look like for you? What could it look? Where could we make other changes? Are there potential places in your family structure, system, or infrastructure at school or other things that you love to do? And some kids will be like, well, yeah, I play hockey. Well, I'm Canadian. I play hockey, or other things, right? Which allows us to say, well, can we build on that? Can we do other things with that? In which case, I'll start kids on tablets. I'll start kids on metformin. And most of the time, parents are happier with that than with injection therapy, certainly. And then we see them again in a month to see how we're doing in terms of care and targets. And I think that, every win is a small win. So if they come back in a month, then we've won. I mean, that's the reality of it, right? And so I don't get a lot of kids who all of a sudden come back with A1Cs of 7%. They're probably still 8.5 or 8.9%, but that's how you start getting engagement in terms of medical therapy and other things that we can do. So I spend a lot of my time as a partner with people who live in communities, more than a subspecialist who flies in and does anything as you know, we don't do anything remarkable. I showed you our data for our kids. They're not all doing fantastic. It's a team. It's a team that is required, and the family's part of that team, and grandmas are part of that team, and aunties are part of that team. And just even knowing where the kid lives, our kids don't live in one home all the time. Up north, they live in multiple homes, and so it's important to understand what the family structure is and the support structure is. And sometimes it's the older sister who takes care of the rest of the kids. Mom actually isn't part of that because she's dealing with her own health issues, or dad's health issues, or her parents' health issues. And so it's all a really important part of how we decide how we're going to manage the care. Yeah.
Brilliant. Thank you. So David just spent 12 seconds writing a script for metformin, which is the easy bit, obviously, to write the script. How do we then, how do we work on helping this young 7-year-old to take those tablets, to take them every day or as close to every day as we can, to increase the dose over the course of, a couple of months, to see if we can get up to a full dose? So I'm thinking about the easy part is writing the script. What can we do in terms of supporting this young fella to manage some of the medication aspects of their care, or the family? And I'm opening it to anyone who's got some ideas.
We'll probably try and catch up with them regularly, or during the week, probably as many days as we can. Practice the swallowing the huge tablet. It's hard to swallow for some kids. Just
got any strategies for that?
Oh,
being very practical here.
Yeah. Water in the mouth, head back, and then forward and swallow when you're down. I don't know. The duck swallow. I don't know. Yeah, meeting them wherever they are. Usually, like I said, knowing where they are and the addresses, or when they're at school, it's sometimes easier as well. If they're at school, get them while they're at school. If they are there, encourage them every day or every second day to take their tablet if we can see them and have a yarn with them. Meet with the families, and yeah, as regular as we can, possibly.
Yogurt's a good tactic, to put the tablet in yogurt and use that to swallow as well. We used to use that quite a lot in the children's hospital. The other thing is the APEG, which is now ANSPED guidelines, do state that we can use immediate acting metformin, so we could crush that one, so that it doesn't have to be as big. But as a nurse practitioner and diabetes educator, our role would be to talk through the importance of the medication and what it's doing in their body. And I like to talk about how it's a little bit like WD-40 for the cell door and helps it open, and use that in conjunction with exercise and talk about how both of them help with insulin resistance. And then a good option is to put the Libre sensor in as well, so they can actually see the benefits of both exercise and metformin working to try and help with adherence as well.
So I'd be interested for you to elaborate on that, and anyone else jump in about whether you're using sensors and how you find that helps with that, certainly with that initial management, early management. Yeah,
so it's definitely a connection to their body. So it's showing them what's happening within their body and how the different foods. So we're seeing a lot of changes when the dietitian's working with them as well. You can see the impact of low GI, high GI foods when they go out and do high intensity exercise, as we're trying to encourage them to do 3 days a week. And then the effects, you can talk about how they're more insulin sensitive for the 24 hours after that. And then that also helps with the adherence to that.
Great, thanks. Sorry.
Yeah. A big part of our job is delivering medications, giving medications. We've got a mixed bag of kids on different things. So when we initially get a client and they start with us, we usually like to see them swallow the tablet or give them the injection and see how they are. And then go from there. Maybe we might deliver it daily to then once a week, to then giving them a Webster pack once a month, just seeing their compliance levels. And we've built relationships with the mothers to know, like, tell us if they've missed a dose. You're not going to get in trouble. No one's going to get in trouble. We just need to know what we're missing here. We've got a lot of kids with chronic lung disease on our program, so they've got to have that weekly dose of azithromycin. That one's hard because they hate the taste of it. So we're always trying to come up with new ways on how to give that again, yogurt, cordial, whatever we can use, because they just need to get that dose in. Injections, we use a lot of different things. We've got the Smiley Scope, the virtual reality things. We've got the shot blockers, little spiky things you can put on their skin to sort of trick their skin into thinking it's something else. Obviously YouTube works well too, and having the carer there. But in a good way and a bad way, a lot of our kids are really good with their injections because they're just used to it. We've got about 20 RHD kids on our program too, so we're going out giving their BLAs, always with lignocaine now because it makes a world of difference. Yeah, so I think just it's trial and error with every kid. You don't want to just assume they're good at it, or you don't want to assume that they're not. So yeah.
Great. And you're providing that early support and scaffolding, and then sort of pulling away as they take the reins, which is really great. Anthony, I think we better move on to our next slide, which I'm just trying to find. Because we can continue some of the same conversations, really. So case 2, I haven't thought of a name yet, Junior. Type 2 14-year-old who's been diagnosed with type 2 diabetes and has an initial HbA1c of 10.2 or 88. There's a background, again, of a very strong family history, actually in this case of end-stage renal failure. There's another story of dyslipidemia. BMI is not elevated, but the waist-height ratio is just mildly elevated, but quite a significant increase in the urinary ACR at presentation. Again, a strong family history of type 2 diabetes. Again, maternal type 2 diabetes later, but gestational diabetes in pregnancy. Mum had end-stage renal failure at 30, and her father had end-stage renal failure at 40. Maternal great-grandfather has diabetes, paternal uncle, and then older brother and sister who were diagnosed during childhood. Slightly different social context, living in a regional town. Junior's not the right name, but Junior anyway, is carer for younger siblings. There's a story of food insecurity again and exposure to domestic violence. And again, school attendance hasn't been great. So we're going to talk about some of the same strategies, but there's a couple of things we'd like to highlight in this one. And one will be the difference in age. So we've got from a 7-year-old in a family context to a 14-year-old who's really in some ways a carer in her family, but also the relevance of the really high ACR and the strong family history of renal complications. And I'd actually like to reverse this and go straight to you this time, Brandy, and just talk about, I guess, if you have taken that first call from, concerned members of the local regional town, what would be the things that you would be thinking about most as priorities for this person, and encouraging the team to look at?
So usually this will be as a pediatrician will call us from First Nations call. We have them covering the communities. So I think safety is the first priority. So I need a urine dip. I need to make sure this kid isn't in ketoacidosis. I need to make sure this kid is safe. And then I'm an endocrinologist, but certainly with the other histories of domestic violence, general safety is an issue in terms of this child, which may be more important than the diabetes at this point. But let's go back to me being an endocrinologist and assume that there's community supports that we can help engage for that. So this is a child that I would need to give insulin to. I don't think there's any other option with an A1C of 10.2%. The question becomes, what is the option in terms of insulin? So in food insecure households, there's a fear of insulin with rapid acting insulin. So normally I will give premixed 30/70 insulin to kids to start with. In kids who might not be able to eat, I think giving rapid insulin can be concerning. So we might start with basal and metformin on top of it in terms of trying to help improve the resistance and let the insulin that we give work a little bit better. It's a tricky thing. My conversation with families is this is what we need right now. we're going to do this for 3 months, and we're going to do it hard because you are young and your body is strong and it's remarkably resilient to this hit. And we might be able to, if we can get the blood sugars down, allow your body to work a little bit better. You're not so glucotoxic. It's like honeymoon in a type 1 kid. You're not so glucotoxic. And in fact, they can come off of insulin often. So we've had kids on 3 months of 30/70 insulin. We take them off the insulin, put them on tablets, and their A1Cs are 7% for the next year, right? So we have had that success before if we can get buy-in from the beginning. The double-edged sword part of that is I'm very, very cognizant that type 2 diabetes in children is not the same as in kids. They have early beta cell failure. And to make children believe that they can go into remission if only they do all of the right things sometimes sets people up for more shame when they come back and their A1C is still 9%. So I never tell a kid, you will for sure come off insulin, because I actually don't know. And if they start jogging every day and they're doing all the right things and their A1 still requires insulin, that's that child, right? Some of that is maybe you were born with a pancreas that wasn't going to work 100% right. Your diabetes is a little bit different than anybody else's in your family or your friends. So I think part of the conversation about insulin is really the individual thing. And I say to kids, it's like having asthma. Some kids have it and they grow out of it. Some kids have it and it's only bad when you get a cold. Some kids have it and they need puffers every day for the rest of their life. And none of that is the child's fault. This is just what you need to be healthy. And so it's a big conversation about insulin. So it's, let's try it to see if we can get you off of it. Let's try it at the beginning. And I'm going to do my best to do everything I can to help you come off of it. But if you don't, that's not a failure. That's what your body needs. And you already have the skills then to take care of it. So that would be my approach.
Great, thank you. I was wondering if either David or Brandy could just touch on the renal aspects as well, whether when you'd be thinking about, or how you think about managing some of the renal aspects of this case.
Well, I definitely would be asking for advice, but one of the things is that people generally and kids included, their care can be compartmentalized into the different body systems, and so it's always good if the pediatrician or the pediatric endocrinologist manages the other systems as well, because then they only have to get to know one person. So and we find that does often happen. So I wouldn't write a referral to the renal people, because I'd be hoping that the general pediatricians or endocrinologists would manage
it. Great. Before I go around, because I just want to ask everyone a little bit, but the other thing that we were thinking about for this girl is just thinking about her mental well-being as well. So I just think we'll keep that in the back of our mind as well. But Edwina, is there anything that you particularly think about hearing this story of this girl, or what is there anything that you would want to help her with or think about, or you think would make a difference for her? You know what? I know you love thinking time. So I'll go to Fiona, and then if you want to just grab this off me, yeah? Because you like to think about things first. Go. Okay, Fiona, what do you think about that? So just in terms of what your approach would be, how it would differ perhaps from what we've already talked about, is there specific things?
I guess from a nursing perspective, we'd be looking at doing some screening as well to look at the baseline mental health. In Queensland, there are some diabetes tools that are available. Something called the DPAT tool that was developed within the transition project that we did. So we could look at some baseline screening. We could look at especially a youth worker or a peer support person to be coming along and supporting the clinicians as well. And yeah, linking in with like child and youth mental health from a starting point to try and to work with the mental health as a starting point, and then just being there. I think with what David was talking about before as well, it's just like being there to listen, and then when they're ready to engage further, like then sort of scaffolding that.
Great. What about you, Dani? What do you think in terms of how your approach might be different for this girl?
I'd probably look at letting her know what's out there to help her, like what services are around. She was in town, regional, yeah. See, like letting her know and be aware of what's available around the town or wherever, like close to her. Try and get her engaging with the services that she might feel comfortable with, or meeting with all the other team that she may already know. Like if it's a little small town, probably know half of the people. Yeah, trying to support her and get her to any services that she wanted. What's out there? There's the youth. You'd put her in the youth group, take her to the diabetes, the cooking groups, help her get into the clinic, or even I don't know. There's many that providing food, all the food suppliers, and how to help with her younger siblings if she's a carer. I think trying to remember.
Yeah, she is. She's looking after.
Yeah, looking
some of
after
them.
the family, try and get them engaging in school, maybe tell her she can have a break, send the other kids to school, help her, get on track a bit if we can.
And so I wonder if you can, I'm just interested to know whether you guys have a particular strategy, particularly to deal with some of those social issues that she's dealing with, and also some of the mental health issues that she's possibly dealing with as well within your program.
Yeah. So again, sadly, we've got a couple of these cases in our program already. We're lucky enough to have a social worker in our team as well. So there's me, a nurse, a 0.2 GP, a full-time social worker, an ALO, and a family support worker, and that's us. So again, big emphasis on getting to know her first before, a stranger's asking about her mental health and everything like that. And when we do enroll them into CHOP, we've got sections of, who's mum, who's dad, what are the siblings, who's nana, like who's in your life. So we have names and we have numbers and we have 10 different addresses that they could be at. So we get everything that we can from that social aspect. So, when we do need to find them, or we know where to go. So yeah, we work really holistically. Well, of course, the medical side is a problem, but we will help them get into school. Or if Centrelink's becoming a problem, our social worker will get involved in that end. Unfortunately, a lot of our mothers and fathers also have chronic disease, so we end up being their nurses as well. So if mum's RHD, we'll give her a needle in the car as well, or her medications. Like, although we're not required to, we just find that, how can parents look after their child if they're unhealthy themselves? So we work in that way, and they see the effort that we put in, the extra, effort we put in for the families, the other siblings they have, so that trust is there. So when it does come time to have those conversations with this young girl about sexual health, about her mental health, we're able to, because we're familiar faces. We've helped out. We just don't jump into that straight away, if that makes sense. But
makes perfect sense.
Yeah, but in these cases where we've built that rapport, we've had success. We've got a lot of services within Congress. We're lucky. So we've got a social emotional wellbeing team. We've got Headspace, and a lot of our kids. We've approached the subject carefully with them and with their guardian. And they are actively seeking, therapy, as well as we sort their mental health and their school and all that. We sort of do everything slowly, but we don't give up. It's just patience. And our stats show really well when we put in all the work and work holistically as a team. Yeah, we can see, like, we had a 14-year-old come on our program a few years ago, and her HbA1c was 15%. Now it's 6%. So that was really good. As well as a BLA compliancy for rheumatic heart, it was virtually nothing, and now it's 100%. And another one I always like to say is this little boy with kidney disease. He had about 14 presentations to ED 6 months prior to coming on to our program, related to his chronic disease. And 6 months in CHOP, he's only had one. And you can see that when although we're busy, we've got the stats to show that when you look after the whole family and you do the running around, that it makes a world of difference. in their lives.
So if you can provide really good, holistic, multidisciplinary care, you can get results. It's really not rocket science, but it's really hard work.
But it's a lot
right?
of effort,
It's really
and it
hard
takes
work.
a special team. Like, we've had people come and go because they can't handle the reality of the lives that they're living in, because we're outreach 80%. So you get to see everything,
Right.
and some people can't cope. So it takes a really resilient team. But when you have that team, you get good outcomes.
Did you want to jump in there, David?
You know, I was just going to say that in a practical way, or what would practically happen is that the visiting midwife would talk about sexual health and make sure contraception, if that was needed. The other thing that often happens at this age is they might be going off to boarding school, and or in some of our communities that are close to the border, they might be sometimes going to stay with family or for funerals across in Queensland, and you know, there's no shared records. If they go to Alice Springs to school, there's a whole new referral down to Congress and that sort of thing. So it's often, there's a big logistic thing at sort of interdisciplinary across services and stuff like that as well.
Yeah, that's fantastic. We're almost out of time. I just wanted to check. That was a no. Did you? I thought maybe you might want to finish off the discussion because it all started from your point of view. Is there anything that you wanted to say right at the end about this story or about what you've heard listening to? I mean, I feel like we've just heard from really an incredible team. Is there any message you would want to give to this team or to anybody else who's listening? No, she said it all already, and she has too. I'm not sure if are we out of time? Yeah. Oh, okay. I was going to say if there's any burning questions from the floor that we haven't covered, I feel like we've covered a lot of, you know, the complexity of managing diabetes. But is there anything that we didn't cover that you'd really like to know at this point before we finish up? Matt.
I'd love to hear more about the CHOP program at Congress. That sounds amazing and completely logical that would work and make sense, yet it's not available in most communities across the territory. Is there formal evaluation and like someone looking at that kind of cost effectiveness? Some of those anecdotes you gave, like clearly you're going to save so much money in the health system. Why don't we pick this up and roll it out everywhere?
Yeah, I think so. CHOP's been around for the last 10 years or so at Congress, but I don't know, I've been in it 7 months and been really trying to rework it and advocate for more staff, a better office space, better outreach sort of stuff for us. So I think just before there's just been no drive, but now I'm in this space. I'm a proud Aboriginal nurse, so I feel like really passionate in primary health. So I've been making a lot of noise at Congress. So I think hopefully, and saying yes to coming to things like this will hopefully, and you know, show interest and stuff, because I really do think that like CHOP should be everywhere, especially like an adult version. Like there are care coordinators at Congress too, but this team approach like it just makes difference. You can see it in our stats. So, and our engagement with our families, like they smash, like a phone smashes our numbers, the first one saved in their phone, you know, like the relationship's there. So it's a really good program, and I'm definitely advocating hard. Yeah.
There was one. Did you want one more question?
Yeah.
I'm not throwing it either. Okay. I just wondered, with a 7-year-old who was overweight, if anyone had had much experience in or success in weight loss when you've got younger children. I mean, my understanding as also a GP is that you can use the sort of the growth curve to your advantage and perhaps get some weight loss. Do people have much experience or success with that with children?
I think this is fair. Otherwise, there we go. I think the nice thing about 7-year-olds is that they still play. The problem with 14-year-olds is they're self-conscious, they're body aware, and they have lots of disordered, dysmorphic ideas about exercise and being in public and doing it. 7-year-olds haven't built that yet, most of them. And so I find that if you can get the resources and the places for them to engage in play of some sort, they're actually quite excited to do that. And so a lot of our communities now are rebuilding, they have tribal days, they're rebuilding traditional games, they're doing the canoeing and all of the other activities. And young people are they're also very competitive young kids. And so they enjoy trying to win the prize of doing whatever. And so we've had some good success working with communities to build those programs for younger kids. Where we haven't had success is the teenagers. It's a huge problem. And you probably know that from yourself. If you grew up in a family where you did sports or activities, you're more likely to do them through the teenage years and as you're older. But if you didn't, certainly those aren't the young adults who are at the gym or playing adult soccer, adult volleyball, right? And so it really depends on your exposure when you're young, which is why we are now trying to expose every kid in the community, even the ones who don't have diabetes, so that they can build those the confidence in doing activity. Yeah,
I thought there was a real market opportunity for some sort of app for children that age for helping them to take meds, to do exercise, getting tokens, and how they love games that might work with kids.
Yeah, there's a lot of gamification. So some of our kids have the virtual reality where they play different boxing games or hunting games or movement games. And then Meant to Prevent is an app that also has like children's yoga and mindfulness and mental health stuff built into other games that kids can, not search for Pokemon, but that idea, right, that you're at least moving and walking about. So we have a lot of kids that will also engage in the gamification. I thought Dance Dance Revolution would be huge. It is not in Canada, but there you go.
Fiona's just got one very quick thing to say, and then we will wrap up. Just because you're asking if you've had any experience. So previously I've worked with the Healthy Kids Club in Brisbane, the Good Start program. So they've had quite a bit of success in that age group as well. And it's a quite intensive 6-month program with 2 weekly follow-up for obesity, but was also linked with youth type 2 as well. So if you look out for that.
Thanks.
Brilliant. Thank you. I'd like to say a really big thank you to the panel. Really appreciate all the different things that you do. It was fantastic. Thank you very much.
Before you go anywhere, Michelle, would you be able to give all of our panelists a gift to say thank you for their time? That was a really great discussion. I think you guys covered some really important aspects of the management of youth type 2, but also just coming back to that point around there are some really amazing things happening in some of our services. Like we just heard about what's happening at Congress with the CHOP service. And I think if we step back for a moment and think about the spectrum of health and how service delivery is at one end and then research is at the other, there's a real opportunity for us to partner with organisations who are doing things really well, but really need the evaluation to underpin the evidence required for continued service, funding and servicing. And so I think that's a really beautiful example of that. And I also just wanted to flag, this is my opportunity to do so. I thought Simon would speak about it earlier from Catherine West Health Board, but there's a new initiative called Health Coaches, which Simon and Paula Burgess have been driving for years now. And that has recently obtained funding for implementation through Catherine West communities. And so the initiative has come from the ground up. It's taken years and years to get to that point, but we've recently within the partnership obtained a tender to be able to evaluate that piece of work so that they can then move forward in terms of scaling up and sustainability. And so I think you can start to see how all of this starts to marry together in a really nice way if it's done properly. Thank you all. Next up, we have our Diabetes in Pregnancy panel discussion, which will be chaired by Dr. Anna Wood. For those of you who don't know Anna is the Head of Department at Endocrinology at Royal Darwin Hospital, and she's also a Senior Research Fellow with us within the Diabetes Partnership. You would have heard this morning that Anna now heads up our Pandora research project, and she also leads the weight management service in the Northern Territory with expertise in cardiometabolic health. Anna is also the director of the Australasian Diabetes Society. So over to you, Anna.
Thanks very much, Renee. Yes. So thanks, everyone. I am feeling very privileged to be chairing this next session around diabetes and pregnancy, and I'll start by introducing our panel. We have Tara Fraser, so I'll go left to right, who is a dietitian working with Malala. So welcome. We have Kammas. So thank you very much for joining us, who is a mother of 3, currently 20 weeks pregnant. So thanks for joining us, and had gestational diabetes in her last pregnancy. Kiarna Brown is an obstetrician and gynecologist in the Territory, working at Royal Darwin Hospital. And Liz Watkins is diabetes nurse educator and diabetes CNC, who has been working in the Territory for many years. So welcome. So we also have a case, if we could flip to the first slide. Thanks, AG. So we'll call our case Kylie. And again, this is a completely fictional case. So Kylie is a 26-year-old woman from a remote Aboriginal community, and she's about 400 kilometres from a tertiary centre. So she has no known chronic conditions and not any medications, but there is a strong family history of type 2 diabetes. And she attends clinic because she is pregnant. So this is her first pregnancy. She's 8 weeks pregnant. Her BMI is 28. And my first question is really for Kiarna and Liz, around, would you be screening this woman for diabetes, for gestational diabetes?
Thank you. Thanks for the question. I guess the first thing to say is that as a obstetrician working at a tertiary hospital, I would almost never see this situation. And so I must actually pay respect and homage to the people who do see this, these women in these situations. And that's really in my line of work, most commonly the midwives and health workers who work in remote community health centres, and also those who work in urban and the GPs who work in urban as well. So I had to brush up on the new guidelines. In many cases, this is a lovely woman to see on my books. She's healthy, she's got no chronic medical conditions, you know, her weight range isn't so bad, and she's having her first baby. That's so exciting. But her strong family history means that she probably does warrant some first trimester screening for diabetes in pregnancy. And I'm so excited that that doesn't mean an OGTT straight away anymore. And that has been a major win, because I guess engaging with women early in pregnancy, particularly in remote communities, is a challenge, as is timing appropriate screening and investigations. So we don't always have a sonographer who travels regularly to all our clinics where pregnancy occurs. So dating a pregnancy can be delayed, but then asking women to do an OGTT early in pregnancy in the first trimester, as you know, is awful. And then if it's negative, it's not even a win because they've got to do it again. It is also a real challenge. But in answer to the question, yes, and I'm glad it's not an OGTT anymore.
Yes, yeah, exactly the same. First trimester can now go straight to HbA1c. And then from there, yep, they still have to have another OGTT at 24 to 28 weeks. But I think it just, you know, will really help just having that early screening just through a blood test. Yeah.
Great, thank you. So next slide, if that's okay, AG. So I guess just to reiterate what both Kiarna and Liz are saying, that recently Australian guidelines have changed, and Queensland and the Northern Territory are broadly adopting these guidelines. And just to highlight exactly what everybody has said, that we would continue to do a routine booking HbA1c with no need for an OGTT, and if the HbA1c is between 6 and 6.4%, that this would be managed as GDM, and so doing less early OGTTs. And we'll talk a bit later in the talk around the change in the thresholds for the actual diagnosis of GDM. So to the next slide. So she has her HbA1c and her HbA1c is 5.5%. So
Great.
Liz, what do you think about this?
Perfect. So she doesn't have diabetes yet at this stage, but given her strong family history and high prevalence of diabetes where she's from, would definitely recommend that she go and have an OGTT at the usual 24 to 28 weeks.
Great. And if we just bring up the slide. So yeah, you answered all of these questions. So it does not have GDM, but still needs a routine OGTT. And just to reiterate, because her H1C is less than 6%. So she then goes on to have her routine OGTT and at 25 weeks. And you can see now that she is diagnosed with GDM based on that criteria. So, so maybe Liz, if you want to discuss her cutoff and why she's diagnosed with GDM.
Yeah, so 25 weeks. We're going to talk about the new guidelines. Yep. So the previous diagnostic criteria for gestational diabetes was a fasting of 5.1, a 1 hour glucose of.
Do you want to do it again, AG? So Liz will have to remember.
And the 2 hour of 8.5. I think that's right. All these numbers.
There we go. Testing you.
So on all three counts there with the new diagnostic criteria, she would be diagnosed as having GDM. So yeah, the new criteria is a fasting of 5.3, a 1 hour of 10.6 and a 2 hour of 9. So she's on all three counts is just slightly elevated, giving her a diagnosis of gestational diabetes.
Thank you. So we might turn to Zal. So you obviously had gestational diabetes. Do you mind telling us a bit about your story and your experience about being diagnosed with GDM?
Yeah, so I've got a 15-year-old and then we had a big gap and then 11 years difference. And then I've got a 4-year-old who's in the crowd and then the last one, a 2-year-old. So didn't have it with the first two. And then with the last one, it was first I had the early screening because of family history, older, geriatric pregnancy. So that came back clear. I think it was about 18 weeks I had that. But then at 27 weeks, it came back as, GDM. But then because I was so sick with the pregnancy, I was on a lot of medication. I didn't want to be nauseous anymore. So I opted for the insulin straight away because I just couldn't do the nausea anymore. Yeah.
Mm-hmm. So you mean rather than having metformin?
Yeah. Yeah. I just
really
said, that was easier for me because, at 7 weeks I was in hospital with severe nausea and vomiting and a lot of medication. Yeah. So I just said insulin's better. And I'll forget probably anyway if I had to take a tablet.
And so the recommendation when women are diagnosed with GDM is to prick your finger 4 times a day to check your blood glucose levels. Are you doing this and what was that like?
Yep, so 4 times a day and then documenting it and then also trying to keep a diary of everything I ate just to see when it was going up, what I had eaten. And obviously at the time I had 2 kids and then being pregnant, mother, wife as well, trying to remember. Yeah. So having to remember to write everything down, document it, and then taking it with me when I was out and about as well. Yeah, that was a bit of a challenge with a 2-year-old.
Yeah.
Yeah, hiding the packet.
Yeah, absolutely. And I guess if we go to Tara, so once a woman's been diagnosed with GDM, what sort of dietary advice are you giving?
There's a couple of layers that I consider before providing dietary advice. Kind of echoing what was said before in the previous panel around understanding what their understanding is of diabetes and explaining that really well. Taking time to do that kind of provides justification as to why there needs to be dietary changes, because GDM or diabetes in pregnancy is really scary and can be a shame job for people too. So I do that. I also want to understand their social situation, how many kids they've got, who's at home, do you have power, do you have a fridge, do you have cooking facilities? They all come as potential things I can work with or change, you know, even if they have access to a takeaway store or what payday there is. I try and get a really broad understanding of their food story because it provides such a huge context of who they are in their world and their social situation. And then you can kind of trickle down to actual carbohydrate manipulation where you're thinking about glycemic indexes or quantity of carbohydrates. But often I just do little swaps because, again, it's really overwhelming. So, you know, if someone's having Coke, swapping it to no sugar or having that discussion, maybe suggesting water, but even then that's not always approachable. Developing a really good therapeutic relationship with someone who has GDM or diabetes in pregnancy, I think is really important because I'm going to be working with that person for a while. Women feel shame so deeply that I really want to make them feel comfortable. So making really small steps around carbohydrate timing, pairing carbohydrates with protein or fat, they're my kind of priorities.
I was just going to add, I often, I mean, I think it's important to reassure people that it's okay if you don't, if you have moments of weakness. You know, sometimes as a woman, you know, when you get pregnant, you're like, yes, I can eat for two now. And then when you get diagnosed with diabetes, it's a real shock. And like you said, it's actually really hard. And when you've got a family, I know I'm a mother, to keep eating healthy every day. And I did want to be a better mother a couple of years ago, and I took home the snack information for my children so that I could start giving them better snacks in their lunch boxes. And even that was really, really hard. And my children aren't sick, and I'm not sick. And you know, I got sick of spending lots of money on cheese because cheese is so expensive now, and then getting it back all melted in their lunch boxes. And so sometimes the women do come and I say, oh, did you bring your diary with you? And they're like, yeah, I had a couple of highs this week. And I was like, well, that's okay. You know, show it to me. And it was cake. And you probably sometimes didn't write down cake because you were so ashamed when you went to see the doctor. Yeah. And you were like, I'm really sorry, but it's like, it's okay. It just can't happen every day. We need to make small changes and get used to making those small changes. And if you have a moment of weakness, that's okay as well, as long as it's not all the time. Yeah, it happens to all of us.
And just another point on that also is that a diagnosis of gestational diabetes is shocking when you hear it at first. And it can kind of, in my experience, instill two different kinds of emotions. So, you know, there might be one group of people who are able to use it as a positive thing to make positive changes and improve quality of life. Then there's another group who do look at it as an embarrassment, shame, and the stigma associated with that. So I think it's good to always ask about that and just talk through it, dispel any myths or, you know, any blame that they may have as well, just to talk through that. Yeah.
Do you want to add anything else, Sal, about your experiences of being diagnosed?
Yeah, I think like I was fairly healthy before I got pregnant, you know, 6 days a week working out. I was a pretty fit person. And then as soon as I get pregnant, I'm bedbound for 20 weeks. That's it, I'm out. So, and then you're trying to think of managing the whole family. And then all you think of is, you know, straight away diabetes. Oh, dad's got it. My grandmother ended up on dialysis. So that's the alarms going off in your head. So I've got to knuckle down. I've got to get on top of this. But then in real world context, I'm running a household at the same time as being super sick. So, yeah, so all of those things. So trying to go easy on myself, be realistic too of what I can do. And then, yeah, then taking care. And then, because you're also thinking, oh, I don't want to pass this on to this baby as well. I've got to protect this baby as well. And but then at the end of it, I'm healthy anyway, and came out good. So I've just had the last early screening just recently, and that's come back clear. So got to wait for the next testing. Yeah, another one.
Thank you. So we might come back to Kylie. So we have given her dietary advice. We've recommended her glucose targets and asked her to prick her finger 4 times a day. So we normally say fasting and then 2 hours after meals, which is an incredibly tricky thing to remember to do. And when you're out and about, as Sal said. So the next slide just shows us her book, which I should have added some blood and food, which they normally have all over them, don't they? So Liz, do you want to comment on her blood glucose monitoring? Sorry to make you bend over.
So, and she's how many weeks now at this point? She was. Yes, okay, because she was diagnosed at 25 weeks, wasn't she? So yeah, immediately you can see there that she's got a couple of fastings above target, one after breakfast and then quite a few after dinner. So definitely start some conversations there about things that she could possibly change just to bring the numbers down a little bit. They're not too bad, but also considering starting metformin at this point as well.
Next slide, please. So yes, exactly. So we decided that we would start metformin, and the maximum dose she could tolerate was 500 milligrams. So that's 1 tablet. They come in 500s and 1000s. And our first question, really probably Kiarna or Liz, around what do you think about using metformin in pregnancy? Is it something you use regularly?
Yeah, I'm often not the one, again, who's initiating the treatment, but I think metformin is fairly well accepted and fairly well tolerated in comparison to other medications. I think that many people in the community, owing to the epidemic of diabetes, are familiar with metformin and know that it is a medication that I just need to take every day, and I know it's going to help my sugars. So I think that people are relatively accepting of it, and I think it's, in terms of managing diabetes, and particularly with numbers like this, it's very useful. And I feel like, we started using more metformin as opposed to insulin earlier in pregnancy as I was coming through my training. And I do feel like it was a game changer for managing diabetes. I think that insulin is really difficult for people, and particularly people who I see in my antenatal clinics.
Yeah, I think that there's been lots of studies and research in Australia, particularly in Australia and New Zealand, that show that it is safe to use in pregnancy. And we've been using it it's been used for many years for people with type 2 diabetes. So I think it would be really important to explain to the woman and her family the importance and why we would even consider using metformin and just how great it can be, but also to acknowledge that not everybody can tolerate it. It can be quite nasty with some nasty side effects. But just to talk through those, what to expect, what to do if you do experience any of those, and next steps as well if they can't tolerate metformin.
And I guess just to reiterate what Liz is saying about and also Kiarna, as the same about the safety of metformin, that there are a number of studies using metformin in PCOS, metformin in type 2, and metformin in GDM. And the general thought is that it is safe. And there's some sort of follow-up studies looking at the growth of the children whose mums are on metformin. And the general thought is that it is safe. There's some sort of differences around the BMI and growth sort of at around age 9. And I think it's just that we need a bit more research around the longer-term outcomes. But I think it's certainly agreed in our context that it's very beneficial and certainly shown to really decrease the need for insulin, which can be a huge pain. But Zal, you were saying you didn't tolerate metformin.
I think as soon as I heard it can make you nauseous, I was just like, I can't do it again. So I just went straight to insulin, and that was just a personal thing, because I'm just bedbound if I'm nauseous. I can't function at all. So for me, it was just easier to go to insulin.
Yeah. And I don't know, Liz, what you think, but I often find women can't tolerate the 2 grams, which is the maximum dose. Often it is a lower dose.
Yeah. And generally we would start at the lowest dose, depending on how progressed the pregnancy is. But yeah, start at the lowest dose and then gradually up titrate from there. And then you can stop at any point. If it's just not well tolerated, you could, like Kylie stopped on 500. So it's still, you know, in some cases helpful for insulin resistance. Yeah.
Great. So she started metformin, and then if you look at her blood glucose levels again, Liz, do you want to talk about these?
She needs
Thank you.
insulin. So yeah, she's got 4 fastings, 1 after breakfast, all after lunch, and a couple after dinner. So looking at those, and we've talked about diet, or Tara will talk to them about some food choices that could possibly be swapped out. But looking at starting Opticillin and probably Nova Rapid with lunch, and hoping that the Opticillin would help with the 1 after breakfast and couple after dinner. But some, you know, clinicians might choose to do differently to that. We would have used Protophane previously, but now that's only available in pen fills. So I think Opticillin, Nova Rapid for Kylie.
Thank you. Tara, did you want to comment at all about her glucose levels?
I'd ask how her fingers are feeling, because that's quite prickly. I'd also be really grateful that this person's putting in so much effort to test their sugars and write them down, because it's hard work, and I certainly would be having sore fingers. So yeah, I'd assume I'd be handed over to from the diabetes educator with many thanks, and kind of approach this with curiosity. I'd just ask what's been happening for you lately. Tell me about your lunches. Get a really good redo my diet history, probably. See if there's any things that I've missed perhaps before, or maybe forgot some drinks, some things that this person might not have shared with me before because I don't know them as well, maybe sharing them with me now. And it really, again, comes down to tweaking carbohydrates. So maybe if they're having, for example, a really common lunch that I see would be something like 2-minute noodles. Perhaps we can add some bush tucker to that, so buffalo or fish, and some veggies to help slow down the glucose response. Other things I would suggest are, go for a little walk after you're done with your lunch with your kids. Get them running around if you can with them too. But yeah, I think that's probably what I would suggest at this stage.
Thank you. So the next slide. So as Liz very wisely suggested, we started her on insulin. So she said Opticillin, which used to be Lantus, which is long-acting insulin that we normally give before bed to help with those fasting glucose levels, and then the Nova Rapid with meals. Liz, you sort of touched on this, but what insulins should we use in pregnancy, and are they safe in pregnancy?
Opticillin and Nova Rapid? Yeah, so we used to use Protophane a lot, but it's just been discontinued in the Innolet device, which is a real shame because it was a pretty simple, easy insulin giving device to use, and it was very big and had a big dial with large numbers to read. So they've discontinued that, and for remote women, we have decided kind of collectively as an organisation to use Opticillin for diabetes in pregnancy. But also locally, where you can get a Nova Pen giving device, you can get Protophane pen fills. So you can still use that for local women. It's just a bit more tricky. You have to get scripts for the pen fills. You have to get a Nova Pen device, and then you have to not lose that Nova Pen device because they're difficult to get a second one. So it's not as simple as, just starting Protophane. It's just got to think about the whole picture. What's easier and the best for that lady.
Thank you. Zal, you mentioned that you were on insulin during your pregnancy. Can you tell us a bit about what it was like to start insulin? Was there anything, did you have any supports or anything that really helped you?
Yeah, so because I was part of the MGP, green team, that sort of helped anyway, because I had a point of contact, and then I think it was I was liaising with Scerri, So that helps, and just being able to just text her, because I just having a look at my emails, I'd run out and say I've only got 2 units left or whatever. And then lucky because my sister works here, so I'll send her up to the floor to go pick up my medication. So like supportive in that way. But yeah, now going forward, I was thinking if I do have it this time around, it's trickier, you know, multiple kids and trying to organize all of that. Yeah, how I would handle it, you have to really knuckle down and yeah, get on top of it. Yeah.
Just the next slide coming through. So I think we touched on this in the youth session, but Liz, did you want to touch on continuous glucose monitoring and its use in pregnancy?
Yeah. So continuous glucose monitoring is a fantastic tool if you're lucky enough to get it. It is, it can be used in conjunction with other things. It's not, you know, like a standalone fix-it-all kind of solution. There's a lot of things to consider when you do have CGM, but it can be a fantastic learning tool. So useful for therapeutic decisions as well as an educational tool for the person who's using CGM. In Australia, the NDSS, it's fully subsidised for women with type 1 diabetes, so they can get it throughout their whole pregnancy, fully subsidised. But unfortunately, it's not subsidised for women with gestational diabetes or type 2 diabetes, although there's lots of, you know, work in that space to hopefully make it accessible to everybody. So failing the NDSS subsidy or you're not eligible for it, it costs between $200 to $400 a month, depending on the device that you're going to use. But fantastic to, you know, give you a lot of information to make informed decisions. Like I mentioned before, you know, there's a lot that goes with it. You do have to provide quite detailed education on how to put it on, how to troubleshoot through things, how to set up alerts and alarms. That can be really helpful throughout the pregnancy. As well as at the end of the census session to get the information and have somebody who's able to interpret all that data and then make meaningful changes. There's the Libre Freestyle 2 Plus that you can get a free trial or a 2-week trial. So we often do that for a lot of people. And for gestational diabetes, you may not need it throughout the whole pregnancy. It could just be used intermittently. But for maybe somebody with a more high-risk pregnancy or type 2 diabetes, our team have been known to ask the companies for some philanthropic sensors. So we've managed to get through it that way. Yeah, but hopefully, you know, they will be accessible to everybody soon, one day.
Yeah, and I think really aligns with what Anna McLean was talking about with her PhD, showing how acceptable they are to women and so you're not having to prick your finger 4 times a day or more. Yeah.
I also use CGMs in my clinics, and it's great. It often will give women a bit of a break off the finger pricking as well. One thing I have noticed anecdotally is that the sensor is so bright and white against an Aboriginal person's skin, can bring attention on sometimes unwanted attention to that person. And that's just something that I've been considering a bit because it is so useful for us as clinicians, for them as well. But yeah, just something that I've had in the back of my mind. I wonder if we can maybe source some of those stickers to help cover it up. Because yeah, otherwise it's a really useful piece of equipment.
I can link you in with the company that does all kinds of different designs and colours and everything over patches.
That would be amazing. Yeah. Thank you.
All right, so if we continue with Kylie's pregnancy journey, so she comes into town at about 37 weeks with a support person. She's induced at 38 weeks due to concerns around reduced fetal movement and a concerning CTG trace. And she has a baby girl by vaginal delivery, 3.6 kilograms. She has some mild hypoglycemia and is managed on the ward, so doesn't need to go to NICU. So Kiarna, the next couple of questions are for you. So I guess coming back to before she delivers, how do you make these decisions around, I guess, where she should birth and when she should birth and how really?
Yeah, great questions that probably we're still working out, and we don't always get it right, and we can accept that. And you know, it probably is a lot of the time clinician dependent, although we do try and use some guidance. I guess when you work in an environment like the top end where we do see diabolical, devastating rates of diabetes and gestational diabetes, and we also see the extreme of the consequences of that, complications of that. It's hard not to, I guess, intervene early, and we so basically, the rules are that we should plan for birth when the time is right. And when the time is right depends on multiple factors for that woman and for that family. And so it's not always about just the numbers, but it should take into account her past history, what other chronic diseases she has, what the glycemic control's been like, yes, but also is there fetal macrosomia? Is there any, indication of IUGR? Is the placenta not working anymore? So there's a whole host of things to consider. I'm a huge advocate for preventing preterm birth and trying not to, intervene too early, and giving people, the time for spontaneous normal birth. But we also know that there is benefit in keeping healthy pregnancies, babies inside, and that every week counts. And so, so it's really a case-by-case basis. And I think the thing is we try not to intervene too early, but we also know that that we get to a certain point and we think, phew, this woman's been in hospital, she's had admissions with, trying to control her blood sugars, or she's had no monitoring and we don't know what the sugars are like. And now she's 36 weeks, it's time, let's just get this baby out. And that's not always the greatest way to make a choice about, make a decision about that as well.
So what would you do for Kylie?
So Kylie, it would have depended on, what the ultrasound scans are looking like, how she's feeling, her sugar control once she's been on the insulin. She probably, because of the insulin, we would probably start to think about induction around 39 weeks. Yeah.
Great, thank you. And the next slide. So she's now postpartum. We stopped all her medications when she had her baby, and her blood glucose levels looking fine. They did a couple on the ward. And so Liz, what are you thinking about postpartum for her as a diabetes educator?
If she did come to RDH, one of us in the team would see her and we would talk to her about the key 5, which is glucose checks postnatally, so the OGTT again, 6 to 8 weeks after delivery, or if that's not able to be tolerated, a HbA1c, but not before 4 months. Breastfeeding, as we've heard today, just how powerful it is, and the health benefits for mum and baby with breastfeeding. Healthy weight and healthy eating and exercise, touch on all of those things. Smoking cessation and contraception, and the importance of planning for future pregnancies, especially if they've just had a pregnancy with diabetes.
Great, thank you.
And linking back into the clinic and making sure that they are going to, they know what to do and who to follow up with.
So did you want to add anything, Kiarna? Okay. I just have one more question for each panelist, really just around your, I guess, final thoughts around your priorities and considerations for Kylie in the short, longer term. Anything else you'd like to add? Do you want to start, Liz?
Probably just don't forget psychological well-being, I guess. Diabetes can be such a heavy numbers game, and we can't forget that there's a person sitting in front of us, and it's important to just ask how they are, how they're coping, and to listen when they tell you, and remember the next time you see them what they've actually told you as well.
I guess, well, from an obstetric point of view, is appropriate spacing of her family and her next baby, and ensuring that, if she wants some contraception, she's got that on board, and that she's gets time to recover and spend some time, growing this baby up, but also thinking about what it might look like for the next pregnancy, and what she might be doing to keep her body nice and healthy and strong, so that hopefully she can avoid having gestational diabetes again.
Thank you. Bye.
Yeah, I think the follow-up, I don't remember having too much follow-up at the end. So going forward, yeah, and then you have multiple complications added on top. So I had a planned induction at 38 weeks, but she came early at 36 weeks, and then it was, and I actually remember being on the ward going, do I need to test my blood sugars? Like, you know, I had been so frantic about it all this time. And no, it's okay, we're finished. But then remembering you still have this 6-week period, yeah, and you've just had a baby, so you're just, everyone's adjusting, yeah. So I think having that follow-up afterwards, yeah.
I don't really do much follow-up, unfortunately, as much as I wish I had capacity. Unless it's opportunistic and I see the little baby in the clinic, I will definitely be running towards them. When I provide my dietary education, I discuss it with them as if it's during their pregnancy, and I also say this is for afterwards as well. What we're doing now is going to be important for the future because of your increased risk. So yeah, if they were to fall pregnant again, I'd probably see them a little bit earlier this time around. The other thing I do, and this is really clinic specific thing, is that I would put risk of diabetes on the child's file on their EMR, just so that everyone who touches base with that child as they're growing will have that in their mind. Yeah, that's unfortunately all I can do.
Perfect. Thank you. I think that those final messages really reiterate this importance of a life course approach, which we've been talking about all day, really. Maybe we've got a bit of time. Are there any questions in the room or online? Could you have a bit of time? Or comments?
Could I just push back from the woman's point of view on the GTT at 6 weeks? If she's got her glucose levels are fine in the immediate postpartum period, it would seem that it's not unreasonable to omit the GT at 6 weeks postpartum and just do the HbA1c at 4 months, because I'm not sure what the 6-week GTT adds other than diagnosing it a couple of months early, type 2. So can I push back on that?
Do you want to keep it there? Or no. So the new ADIPS guideline just focuses on screening and diagnosis of GDM. ADIPS is working now on consensus guidance around management of GDM that will include postpartum follow-up. And yeah, I'd be strongly advocating along those lines. I think HbA1c screening is way more acceptable as a screening test. I don't necessarily see the point of the 6 weeks OGTT, as long as you do some immediate finger BGL monitoring postpartum in hospital. I'd agree. There's
Yes,
questions
I think
online.
we all agree with you. Yeah.
Questions online? Yeah.
This is a question from Rulin, and it might be addressed to you, Anna, potentially. Would Toujeo be a suitable option, considering they come with a smaller quantity option? Thank you.
Yeah, do you ever use Toujeo in pregnancy, Liz? I think, I mean, it's all about sort of, so Toujeo is the concentrated, it's still insulin glargine, so still the same pregnancy category as Optisolin. So yes, it could be an option for women who are on very high doses. Yep.
One more around insulin in pregnancy. Do experts agree that insulin is the first line of management in GDM, as long-term effects on mitochondrial function of the child are still unknown and may manifest as predisposition to obesity and insulin resistance later in life? There seems to be a theoretical risk. I presume the theoretical risk is, it doesn't mention metformin in the question, but I don't know if that,
yeah, I think
person 169416.
Yeah,
Sorry,
I mean, they might want to tell us a bit about mitochondrial function. I'm not across that literature, but I think we sort of touched on this, and I think maybe this is related to, they did mention BMI. Is that what they said? Or just growth, maybe?
Is insulin first line, long-term effects on mitochondrial function of the child?
The predisposition. Yeah, sure. So, yeah. So, I mean, certainly in our context, as we talked about, we do use metformin first line. And of course, it has to be individualized. We probably wouldn't use it if we're worried about the baby being small. And of course, if women can't tolerate it or they don't want it. And the concerns are from, it's the MIG tofu study, where there was an Australian arm to this study. And so when they looked at the kids of mums who are on metformin versus mums who are on insulin, they found, I think it was at 2 years, that the kids on metformin had higher subcutaneous fat. And then they thought maybe, well, maybe this is a good thing. Maybe they've got more subcutaneous fat, so they've got less fat around their organs, but we don't really know. And then they followed them till they were 9, and then they found actually they do have a higher BMI, but how, you know, the numbers aren't huge, a couple of 100 kids, I think. So I think the answer is we don't know the longer term. We know it's not hugely significant, I guess, and compared to the benefits we know in women of getting their glucose levels down. So I think in a population, yeah, like ours, we've got very high rates, and it's very hard to manage, as we've heard, to manage hypoglycemia in pregnancy. I think we're all quite comfortable using metformin, but it has to be a discussion. I don't know about the mitochondrial dysfunction, sorry, if anyone else does. Does anyone else want to add to that about metformin? I know, I mean, certainly it's not universal that metformin is first line.
Ready?
Right.
What in your experience have been the main barriers to engaging women in care? And then conversely, if you were to try and improve the engagement levels, what would be the enablers in a program?
Yes. Anyone? Yes. I mean, I think there are so many things that we can do to help women, you know, with information, with education, empowering them, and building that rapport, you know, giving them confidence and not saying, oh, look, these numbers mean you're failing, because it doesn't. It just means it's getting harder, and, you know, and maybe what you actually need is a bit more support. So I think, you know, that empowering people with the right information and with the right tools and the right resources makes a huge difference. I forget the first part of the question, sorry.
Well, they were the barriers you've given,
Right.
so the enablers you've given.
And just, I guess, geographical location as well. For Kylie specifically, she was 400 kilometres away. I don't know what resources are available, you know, in community, but I do know that we have the remote antenatal diabetes service here that Dr. Matt Hare runs with our nurse practitioner candidate, and that can be, you know, they're a support for people in community in caring for women with diabetes in pregnancy. So that's, you know, one kind of solution to, you know, pretty significant barrier.
Just talking about another life when I was looking after when myself in a smaller community. I was always interested in, some days there were good numbers and some days there are bad numbers in the same person. So I'd often not look at the bad number, but I look at the good numbers and say, they're really good on those days. How did you go on those days? And my point being that sometimes insulin seems to be, you can keep going with a bad diet if you take insulin, and we focus on the bad numbers and start insulin, when lots of times much more important than the insulin is the eating and the exercise. I don't know. I just think there can be a focus on too much on the drugs and not on the good days, and why were the good days good? I don't know if you have a comment on that.
Tara, you were going to say
I was just going to touch on the barriers before, because I don't work urbanly at all. I work only in West Arnhem Land, and so I follow the women through their pregnancy. And some barriers that I've noticed anecdotally are language, and diabetes is a hard concept. When I was in uni, I was struggling to get my head around it. So I can't imagine someone who has quite low health literacy is going to be able to hack diabetes pretty quick. The other issue that I have seen is the connection with the clinic. Clinics are really sterile, and people almost can feel ashamed to go to the clinic as well. So I think being really flexible in where I hold my clinic, that's probably something that I find rewarding as well, is kind of just hanging out by a tree at their house, having a yarn. speaking in really simple languages is going to get me and that person so much further than taking them into a sterile fluorescent lighting room and talking about their sugars. But I did address it.
But I think you'd agree diet's important.
Yeah, well, totally. And I think thinking about things the fitting way, right? Like I'm a balanced person. I can come in with my clinical expectations, as we probably all do, and want to save this person, change their trajectory. But it is really thinking about it through their lens. What's important to them? Being on country, going hunting and fishing, enjoying that food, having one muscle outside, and celebrating those things is amazing and special and sacred to be a part of when someone shares those things with you too.
Kim, you're so far away. Sorry.
Ooh. I'm just wondering, at what point does somebody talk to Kylie about stress and sleep and things like that that'll impact her glucose? Is anyone talking to her about stress and sleep?
Yeah, good idea.
Yes, I think I actually forgot to mention when we were talking about as Kylie was transitioning onto insulin, she had those high sugars. That's a great opportunity to ask, how is your sleep going? How stressed is your family? Humbugging you heaps, or kind of seeing if there's a bit more of a social background behind that rather than actual food is so important, and that really can drive up sugars, as we know, as well as people being sick, which is why, diabetes is a multi-system disease to manage. It's not just about sugar.
And I guess also, just like I mentioned before, asking about their psychological well-being, their stress levels, and it often does come up, their sleeping patterns as well, because you do need to know that when you're titrating insulin and when you're talking to them about the sugars.
All right, we might have finish a few minutes early if there's nothing else. But if everyone wants to join me in thanking our fantastic panel, thank you very much.
Thank you for two really fantastic panel discussions. Before I wrap up this afternoon or today, everyone will be getting an early minute. You'll be stoked to hear that. We have an evaluation survey. It's what researchers do. We really need your feedback and input so that we can ensure we really think about what next year might look like, and we are tailoring the symposium to meet your needs and requests as best as we possibly can. So if you could just take a moment to have a go at using the QR code if you can. Oh, no reception. That could be a real problem. Yeah, we will make sure we email the QR code to everybody, but please do make sure you take a moment out of your day. I don't expect you to do it on the weekend, but maybe early next week, just to provide us with some feedback, because it is really fundamentally important. I guess just to wrap up, I think today's been a real showcase of where we've come from as a group in the partnership and what's been really important. So I think firstly, Liz Moore really emphasised in the panel discussion that you were on, Liz, that you've been involved in the from the beginning, from Northern Territory Diabetes in Partnership, from 2011 as a member of AMSAMP, but also as an individual investigator. And I think something you said was really profound, in that all of the work that we have done has only been possible because of those relationships and partnerships which were established from the very beginning. And if you look at the work that we continue to do, it is those key groups and stakeholders who have continued to support and collaborate with us along the way. I think the other really important thing is to note and to take away is that we started off really focused on looking at what can we do within the health system space, and also the Pandora study is continuing, which is a really, really fundamental piece of work that we will continue to do. But over time, we've understood that those things only tell us a part of the picture. And where we've come to, I think, over the last almost 15 years, is that we really need to sit down with community. We need to listen to what women, family, young people, communities are saying, what their needs are, how it is that the work that we do can capture that, and then work with our partners. So not only the communities from which these people are coming from and belong to, and working with community and with, not just for, we're moving a step ahead, right? Ensuring the partnerships we have with the health services, the art shows, the other really key partnering bodies and communities, thinking about schools now. We're really stepping into that education space when it comes to working with youth, and that's sort of, I think, the next big focus within that body of work is really thinking about who those partners should be and how do we meaningfully collaborate with them. The nutrition space, we're starting to make a few little inroads across some of the work that we're doing. And so when you think about all of that, we've also shifted along the way from having an individual focus to having a more holistic focus, and really taking on board what are the social determinants and cultural factors that we really need to be considering and taking on board when we're trying to create, develop, embed and sustain change across all of the facets that we're working in, because it really is about taking a holistic, multidisciplinary approach. And I think the panel discussions this afternoon really highlighted why multidisciplinary care and approaches are so critically important. And it's not about positioning the responsibility and blame on individuals. We know that. It's about shifting that and thinking about the broader context in which people live and how it is that we can work together to provide better supports and shift policy along the way. So thank you all for coming. It's been a real pleasure to have you here. Thank you to everyone that contributed in terms of speakers. We do value the time that people have taken out of their days and their really busy lives. A whole day, if you've committed a whole day, thank you. I know it's not easy to take a whole day out of your busy work programs and other commitments, but it really does show us that, you know, you're in here for the long haul, and we look forward to continuing our partnerships and collaborations going forward. So thank you all. Have an early minute.